Good morning. My name is Avirup Guha. I'm the Director of Cardio-Oncology at Georgia Cancer Center. I would like to thank ZERO for inviting me to present on the topic prostate cancer and cardiovascular disease. Thank you, Reggie, for the kind introduction. Today we cover the following topics. Are men with prostate cancer at a higher risk of cardiovascular disease? Are black men with prostate cancer at a higher risk than white men with prostate cancer for developing cardiovascular disease? What is the role of chronic toxic stress in cardiovascular disease amongst men with prostate cancer? How can cardiovascular disease and prostate cancer be mitigated? We will get started with our first topic. Here is a slide deck presented from the Radical PC1 study, which enrolled patients from 5 different countries, where 2,600 men with prostate cancer were consecutively enrolled with a mean age of 68 years. 8.2% of patients had metastatic prostate cancer. It's interesting to note that 22% of these patients had known cardiovascular disease, and 99% of these patients had uncontrolled risk factors. The risk factor studies here are obesity, which 90 to 95% patients had, hypertension control, which suboptimal control was noted in 75% of the patients, hyperlipidemia control, 50% of the patients, both with CVD and no CVD, had poor control, and the other risk factors studied were activity level and smoking. 57% of the patients, both in combined CVD and non-CVD, had poor global risk factor control. This is a summary of data from the SEER data set, where patients with various cancers were followed over a period of 10 years. It is interesting to note that all cancers, when they get far enough from cancer diagnosis, have a high likelihood of dying from heart disease. Specifically, in terms of prostate cancer, as shown by the figure on the bottom right here, cardiovascular disease mortality at 10 years higher than prostate cancer mortality. So what is the CVD prevalence in men with prostate cancer? Here I have put in data from patients who are from the US national cohort of non-cancer standard population, and it is seen that stroke, coronary heart disease, and heart failure are seen in 2.6%, 8.3%, and 2.5% of all males when you look at the period of 2015 to 2018. Amongst non-Hispanic black males, the percentage of stroke, coronary heart disease, and heart failure are 4.1%, 6.7%, and 3.6% respectively. The prevalence in cardiovascular disease amongst men with prostate cancer with androgen deprivation therapy is somewhat similar in terms of stroke and coronary heart disease compared to the general male population. Among those without androgen deprivation therapy, the rate of stroke and coronary heart disease is actually lower than the general population. Let's study a little bit about androgen deprivation therapy and how that increases cardiovascular disease. Androgen deprivation therapy is a group of various medicines, and on the left side of the figure, here we show the hypothalamic pituitary hormonal axis of how testosterone is generated and how that has effect on prostate cancer through the androgen receptors. The various medications have been introduced to reduce the activity of this axis, to reduce the total testosterone load on the prostate cancer, thus acting as treatment for prostate cancer. The most commonly used medications, which are referred to as androgen deprivation therapy, are GnRH agonists, leuprolide, goserelin, triptorelin, and hystrelin. The less common group of medications also referred to as androgen deprivation therapy is GnRH antagonists, degarelix and relugolix. And then other medications used through various pathways to reduce testosterone activity on prostate cancer are androgen biosynthesis inhibitors, abiraterone acetate, and second generation androgen receptor inhibitors such as enzalutamide, apalutamide, and darolutamide. The effect of combination of ADT plus any of these medications or ADT alone has been seen on effect of muscle, which leads to sarcopenia and decreased exercise tolerance. In terms of numbers, lean body mass reduction is seen in 5% of the patient, and fat mass at the subcutaneous tissue level is seen in about 10% of the patients. In terms of cardiometabolic health, androgen deprivation therapy causes dyslipidemia, diabetes, and central adiposity. It's noted that LDL increases in about 7.3% of the patient, triglycerides increase in 26.5% of the patient, and diabetes worsens in 60% of the patients. In terms of hypertension, it is noted that hypertension increases about 20% of the patients, and high-grade hypertension is seen in about 6.9% of the patients. So why is CVD noted to be lower in men with prostate cancer? Androgen deprivation therapy increases risk in the first 6 months, and those that survive prostate cancer, the risk goes to baseline. Lower risk is noted at lower stages. However, as we get up in the stages of cancer, this difference disappears. Also, it is interesting to note that patients entering registries are more likely to undergo routine screening for early detection of prostate cancer. Hence, they are noted to be at lower stages. Also, those are the same patients who are more likely to engage in healthcare systems for preventive cardiovascular care. In general, if you are unable to enter the denominator of the population because of lack of access to such registries, then it's likely going to show the outcomes as we showed earlier. This is exemplified with this meta-analysis of randomized controlled trials looking at CVD mortality amongst various RTOG trials. It is seen that the relative risk of mortality, CVD mortality with GnRH agonists is insignificant for CVD death upon metallizing these 8 studies. There has been recent discussion about the role of the different types of androgen deprivation therapy and the cardioprotective nature. Here are 2 studies which have been heavily talked about. The PRONOUNCE study, which studied degarelix versus leuprolide. And the study, even though it was stopped prematurely, adjudicated MACE, and it was noted that patients with degarelix compared to leuprolide at 15 versus 11 events in the follow-up period, the hazard ratio was not significant in this relatively smaller study. The HERO study, which was a randomized controlled trial published in the New England Journal of Medicine, which followed patients for all of the 48 weeks of follow-up and compared relugolix versus leuprolide, showed that the hazard ratio for cardiovascular events at 48 weeks for relugolix was statistically significant at 0.46. In fact, 3.6% of the patients in the relugolix group had cardiovascular events, and 17.8% of patients receiving leuprolide had cardiovascular events. This led to the recommendation by the International Cardio-Oncology Society, which said that GnRH antagonists should be considered in patients with pre-existing symptomatic coronary artery disease who require androgen deprivation therapy at a level of evidence 2AB. A new phase 3 randomized open-label clinical study, the REPLACE-CV study to assess the risk of MACE associated with relugolix comparing with leuprolide, is ongoing right now. Androgen pathway inhibitors, like we saw earlier, also have known cardiovascular events. For example, abiraterone and enzalutamide have been associated with hypertension. Abiraterone and enzalutamide have also been associated with fluid retention and edema. So in summary, cardiovascular risk factors are high and uncontrolled in men with prostate cancer with as high as 90% obese. Cardiovascular disease affects 20 to 25% patients with prostate cancer. CVD is the largest cause of mortality at 10 years from prostate cancer. Men with prostate cancer have an increased risk of CVD due to androgen deprivation therapy in the first 6 months. GnRH antagonist versus agonist story is to be told yet. Prostate cancer survivors in epidemiological studies tend to have lower cardiovascular disease prevalence after the 6 months of survival, perhaps since screening and detection of prostate cancer is also select for those who screen and control CVD risk factors. With that, we move on to our next topic: if black men with prostate cancer are at a higher risk than white men with prostate cancer for developing cardiovascular disease. Here is a map of mortality from prostate cancer presented across the United States. The age-adjusted mortality for 2000 population from the years 2015 to 2019 was 18.9 per 100,000. Here we see a trend of mortality spread across the different states. As you know, Georgia, where I'm located, has mortality between 21.8 to 24.1 per 100,000. However, the mortality for black men with prostate cancer is 37.9 per 100,000 in the United States. In fact, if you look at the mortality for black men due to prostate cancer, the mortality for black men is almost 49 per 100,000 in the southeastern states, including Georgia, where I'm located. Here we see a table which shows the leading cause of death among non-Hispanic black and white men. And the number 1 cause is heart disease, number 2 is cancer, not specifically prostate cancer. And it's seen that there is significant disparity in death rate due to both causes in non-Hispanic black versus non-Hispanic white men. Here we explore the cardiovascular mortality in non-Hispanic black men. This data was a little difficult to find, and we only have 2 studies to present here. The first study was a study done by colleagues where they combined data from VA, SEER, and radiation therapy cohorts, where they defined overall mortality, cancer-specific mortality, and other cause of mortality. Here I present the other cause of mortality in a fine and gray model, fully weighted. There's 30% increase in other cause of mortality in black men compared to white men with prostate cancer. The other cause of mortality likely includes cardiovascular mortality. However, it is not just cardiovascular mortality. In a study which looked at only cardiovascular disease mortality, and this study combined data from Massachusetts and Pennsylvania, and they studied data from 2000 to 2015 and presented data with 4-year time points: 2000 to 2003, 2004 to 2007, 2008 to 2011, and 2012 to 2015. And it was noted that the racial disparities in cardiovascular mortality has widened over time, and this is comparing African Americans to Caucasian men. It was noted that there's an increasing trend in cardiovascular mortality in the Pennsylvania area compared to and not present in Massachusetts. However, these increasing trends of cardiovascular disease in black men compared to white men was seen only in localized disease, but not in metastatic disease. What about cardiovascular risk factors? There's no race-specific data and regarding what happens to risk factor after starting ADT. However, there was a study done by colleagues from the VA cohort where they included 90,000 US veterans with prostate cancer, of which 32.7% were non-Hispanic blacks. 68.1% received comprehensive CVD risk factor assessment, and 54.1% were noted to have uncontrolled risk factors. Of these 54.1%, 29.6% were not receiving risk-reducing medications. However, if you see on the figure on the right here, over a period of time, this trend has improved, and risk reduction techniques have improved over time from 2010 to 2017. What was interesting to note was when they did a risk adjusted analysis for reasons for lack of comprehensive risk factor assessment, white men were less likely to get a comprehensive risk factor assessment compared to non-white men. The real details was in the supplements, where I saw that amongst those who were excluded, which is 2,197 patients who did not end up in the analysis, there were a fair bit of black men who never got any screening done, mainly because they didn't even have a primary care visit. So in summary, cardiovascular disease mortality is higher in black men compared to white men. Data from southern states need to be looked at further. No data regarding cardiovascular disease incidence is presented based on race. CVD risk assessment is poor across races, even in systems with equitable healthcare such as the VA hospital. Difference in CVD mortality, as noted in Pennsylvania, may be related to social determinants of health and associated with chronic toxic stress. Now we'll study the role of chronic toxic stress in cardiovascular disease among men with prostate cancer. Social determinants of health, which we see in this figure over here, which includes educational status, access to care, neighborhood metrics, relationship metrics, and socioeconomic levels, which includes family income and personal income. The same paper which looked at the difference in cardiovascular effects because of race also looked at neighborhood socioeconomic position. In this paper, they defined neighborhood socioeconomic position as census level tract measure, which included poverty, median family income, households with female head percentage, proportion of income coming from rent, proportion of whites, proportion of blacks, proportion of unemployment, proportion of male employment, proportion of patients receiving welfare assistance, and the joint race income index of concentrations of extreme. Further, since Massachusetts and Pennsylvania had different geographic areas, they used a unique metric using the Environmental System Research Institute's data to calculate the distance traveled by men to come to the healthcare system using ArcMap. What they see is cardiovascular specific mortality is high in those who are on the 5th quintile of NCEP, which is highest level of disparities compared to the 1st quintile of NCEP. And this has persisted at a high level from 2000 to 2015. On the figure over here, it is noted that neighborhood socioeconomic position contributes to cardiovascular disease in men with prostate cancer more in Pennsylvania compared to Massachusetts. However, overall, it's high across the years and has maintained the numbers as we talked about. We'll talk a little bit about what is allostatic load. So allostatic load or chronic toxic stress is because of environmental stressors, major life events, and trauma and abuse. Let's put it into perspective for prostate cancer. Prostate cancer patients have a major life event, which is prostate cancer. I consider androgen deprivation therapy as a major life event because it's a new chemical introduced into their system. They have adverse socioeconomic position or social determinants of health for various reasons, which includes work, home, and neighborhood environment. And lifelong trauma and abuse can lead to this adversity as well. These different levels of adversity in social determinants of health leads to individual level adaptations, which is called allostasis. Allostasis is the action of the autonomic nervous system, the hypothalamic pituitary adrenal axis, the cardiovascular, metabolic, and immune systems to protect the body to these internal and external stresses. The price of this accommodation to the stress can be measured as what is called allostatic load. This is the usual wear and tear that results from chronic overactivity or underactivity of the allostatic systems as mentioned above. Here is an adaptive model. Allostatic systems respond to stress. So this is where a stress happens. And we see this in the upper panel over here. And it initiates the adaptive response and sustains it until the stress ceases, which is the plateau over here. And then after the stress is over, the allostatic system shut down and we see recovery. Allostatic responses are initiated, which is seen in the lower panel over here, by increase in circulating catecholamines from the autonomic nervous system, glucocorticoids from the adrenal cortex. This sets into motion adaptive processes that alter the structure and function of a variety of cells and tissues. These processes are initiated through intracellular receptors for steroid hormones, plasma membrane receptors, and second messenger receptors for catecholamines. The crosstalk between catecholamines and glucocorticoid receptors signaling can occur. The top panel on the figure in the middle shows the normal allostatic response. The different glucocorticoid level and catecholamine level go up, and then after the stress is over, they plateau and then they go down. Over here, we see the effect of repeated stress. These are the 4 conditions which are noted. Number 1, from repeat stress, from multiple stresses. The second level, where there is lack of adaptation to different types of stress. Prolonged response, or patients who have stress but there's no recovery. And inadequate response that leads to compensatory hyperactivity of other mediators. For example, inadequate secretion of glucocorticoids resulting in increased concentration of cytokines that are counter-regulated by glucocorticoids, which leads to a pro-inflammatory milieu. How do we measure this? There's various different markers of measuring allostatic load. Generally, in literature, allostatic load can be measured by these 11 markers, and it's a yes and no answer. Systolic blood pressure greater than 140, diastolic blood pressure greater than 90, heart rate greater than 100, total cholesterol greater than 240, HDL less than 50, triglycerides greater than 150, hemoglobin A1C or marker of diabetes greater than 6.5, obesity or BMI greater than 30, glucose levels greater than 110, C-reactive proteins greater than 3, and interleukin 6, which is an inflammatory marker, greater than 1.8 picogram per ml. Here we study the role of allostatic load in men with prostate cancer and the racial differences. We studied a cohort out of Cleveland, which had 7,168 men with prostate cancer. The use of androgen deprivation therapy was noted to be about 20.9%. A lot of these patients had radiotherapy at 31.9%, and chemotherapy was performed in 4.2%. Only a few of these patients were metastatic prostate cancer at 6.2%. It was noted that 1,570 patients were non-Hispanic blacks and 1,498 patients received androgen deprivation therapy. During the 1-year time point prior to prostate cancer diagnosis to after the prostate cancer diagnosis, the addition of androgen deprivation therapy led to increase in allostatic load across both races. In fact, the pre-prostate cancer allostatic load was noted to be 2 across the board, except in non-Hispanic black men, where it was 3. The median was 3, and over a period of 1 year, the allostatic load went up. So the increase was 0.14 in all the patients, and it was higher in non-Hispanic white patients compared to non-Hispanic black patients, but this difference wasn't statistically significant. What was interesting to note that pre-cancer levels of chronic stress and non-ADT related increase in allostatic load was higher in non-Hispanic black men, which may explain the racial difference in ADT related CVD. And Woodit was studied in another paper where we studied the effect of allostatic load on CVD after prostate cancer, which is being presented at this American Heart Association meeting. Here we had 5,261 patients with prostate cancer who had subsequent follow-up for at least 2 years, or if they died during the 2 years period. 6.6% of these patients had a 2-year MACE. For every 1 point increase in allostatic load prior to prostate cancer diagnosis, the risk of major adverse cardiovascular events increased 25%. In fact, this remains significant across the various different individual events, which included heart failure, ischemic stroke, acute coronary syndrome, and atrial fibrillation. For allostatic load calculated 2 months, 6 months, and a year after prostate cancer diagnosis, the MACE rates remain somewhat similar, and it remained uniform across the board with different types of MACE, as we note on the bottom right corner. So in summary, differences in CVD mortality, as noted in Pennsylvania, is related to social determinants of health and associated with chronic toxic stress. Chronic toxic stress or allostatic load is higher in non-Hispanic black men coming into prostate cancer and increases during prostate cancer treatment with androgen deprivation therapy. CVD events in men with prostate cancer are related to that increased chronic toxic stress or allostatic load. Next, we study the role of various things we could do to mitigate this risk for cardiovascular disease. I only have one slide where we go over the ABCDE algorithm. A is awareness of heart disease. All the things we talked about androgen deprivation therapy can do, what are the risks associated with prostate cancer development and prostate cancer medications, is the part of the awareness which I provide to all my cancer patients. Use of aspirin is recommended in men with prostate cancer as a preventive measure for primary prevention of cardiovascular disease. To pay special attention to certain anti-cancer medications used in men with prostate cancer, which can cause certain arrhythmias due to prolongation of one of the EKG intervals called QT. B stands for blood pressure management, and the goal blood pressure being less than 130/80, and to follow biomarkers in men with prostate cancer, which include cardiac-specific biomarkers outside of the PSA, which is troponin and brain natriuretic peptide. C stands for 3 things. Smoking cessation, as we know, is a big risk factor and risk factor management technique, which helps in management of cardiovascular disease. Cholesterol control or lipid management using statins, and we are gathering data regarding use of calcium scoring of chest CT scans done in men with prostate cancer and its use in risk stratifying men starting androgen deprivation therapy. D stands for 3 things, which is diet, diabetes, and drug choice. Diet specifically follows the American Heart Association Heart Healthy Diet. Diabetes, we look for diabetes in men with prostate cancer and then look forward to controlling the diabetes using various medications, including metformin. And the drug choice, and here's where the story regarding agonist versus antagonist is going to be clarified over the next few years. But currently, the drug choice lays with intensive prostate cancer treatment versus just an ADT-based backbone, where the risks are different. E stands for exercise, EKG, and exposure, where I recommend American Heart Association's Life's Essential 8 related exercise treatment, which is 30 minutes a day, 5 days a week as a prescription to all my men with prostate cancer, regardless of their physical activity status. And we slowly go up to 30 minutes a day, 5 days a week, starting from 1 minute a day. The EKG and exposure are related to the A's, where EKG at baseline is recommended with men with prostate cancer starting treatment to get a QT measurement, which is the interval which can prolong because of cancer medications. And exposure is relevant to the length of treatment with androgen deprivation therapy. It is known that longer they get treated with androgen deprivation therapy, more is the damage to the vasculature and increase in vascular risk. It is important to consider that current risk stratification algorithms were determined using data that had less than 5% non-Hispanic Black men with prostate cancer and did not consider any social determinants of health or allostatic load. New risk stratification algorithm and preventive measures are needed to make this algorithm better. With that, I have my overall summary where we see that cardiovascular disease in prostate cancer is a complex topic. Radical PC1 upon completion will give nice epidemiological insights. Risk factors plus androgen deprivation therapy is responsible for additional cardiovascular disease events beyond the age expected cardiovascular disease. There is significant variable and unanswered questions about racial differences in cardiovascular disease in men with prostate cancer. The difference in cardiovascular disease due to race is due to increased allostatic load or chronic toxic stress affecting non-Hispanic Black men more than non-Hispanic white men. Use of ABCD algorithm to mitigate cardiovascular disease risk in men with prostate cancer, especially those starting ADT, is strongly recommended. And with that, I would like to thank ZERO for inviting me for this presentation. Here I have a picture of my daughter who just turned 1, and we celebrated her birthday just last week.
Great. Well, thank you so much, Dr. Guha, for that presentation. And so I'm realizing that for many of our listeners, the field of cardio oncology might be new, and some of the things that you presented in terms of, as prostate cancer patients are navigating care, this notion that pre-diagnosis stress has an impact on cardiovascular outcomes.
Yes, that is what we are finding, and it was very interesting to actually look forward to that research because it had never been done before. In fact, if you saw the research coming into it, it was very scarce. I mean, I thought I could just make a presentation from the state of Georgia and data from it, and I didn't find anything, so I had to zoom out and look in the United States. So I think there's a lot of research to be done, but I think that effect of chronic toxic stress was definitely something very stark, even in one institution's cohort, which included a lot of Northeast Ohio.
Mm-hmm, mm-hmm. And then sort of the treatment that people get as they're navigating prostate cancer treatment can also then influence cardiovascular risk factors. So how should patients sort of think about, the treatments that they select, and then the impact that could have on cardiovascular events as they're navigating care?
I think the ABCDE algorithm still stands true. I think the first contact with healthcare, I think, is very important. I mean, the initial approach of screening for prostate cancer, getting diagnosed with prostate cancer, getting quick care, and to have cardio oncology involved and on board along with our urology and medical oncology colleagues in treatment decisions and risk factor management, and prescribing the appropriate medications such as statin, aspirin, etc., generally ends with a good prognosis. Although there's research going on in this space, but I would imagine that if equitable care is provided from the cardiovascular standpoint, I think regardless of someone's race, we can mitigate risk factors and control prostate cancer and cardiovascular disease associated with it.
Something else that I found really interesting was at the beginning of your presentation, you mentioned how highly prevalent cardiovascular risk factors were. And so given how prevalent those risk factors are, is that something that, patients should be, talking to their oncologist about as they're navigating treatment, that is getting or ensuring that there is some cardio oncology sort of consultations going on there to make sure that, both of those conditions are being managed?
Yes, and I think this is very dependent on the part of the country you're in or part of the world you're located. Because what happened is for so many years, cardiology and oncology were separate fields. Very recently, since 2009, since International Cardio-Oncology Society has existed, the fields have slowly started coming together. And really, in middle of the previous decade is where everything came together. So I think there's slow uptake in various parts of the country, but I would say it is very important for prostate cancer patients, and I enable my patients more than enable the field itself, is to, if you have any pre-existing conditions, maybe cardiac, maybe non-cardiac, bring it to attention of medical oncologists. It might be very relevant to mitigate some of those issues before your treatment starts.
Mm-hmm. Well, and two, my last question is about that ABCDE sort of framework and sort of, things that patients should be aware of. But honestly, that's a lot to put on patients who are navigating care. So is this something that, all oncologists or all cardio oncologists are aware of and that they bring to the clinical encounter? Or what is the stage of sort of ensuring that, patients know about it, but especially that providers know about it?
I think that's the reason why our specialty has almost taken off, I would say, because there's so many survivors. In fact, by 2040, we're expecting 25 million of all types of cancer survivors. I bet a lot of them are prostate cancer survivors because of how well our medical oncology colleagues have done. I, in my clinic, have a framework which we follow, and it is written like that. I go over it with my patients, but I don't think so it's commonplace. I would imagine a cardiology clinic where somebody comes in with prostate cancer, they're talking a lot about the heart. And in medical oncology clinic, they're talking a lot about the cancer. So a lot of the overlap clinics are slowly coming up. I think most academic medical centers have it. Some non-academic big institutions also have cardio-oncology care. I'm hoping more for it, but most of us who are working in the space definitely go over all these details.
Okay. Well, one thing that I didn't mention to our listeners is that Dr. Guha is a member of our Health Equity Task Force here at ZERO, and we're so glad to have his input on our team, because we are eager to raise awareness around these issues at the intersection of cardiology and oncology. So Dr. Guha, thank you so much for presenting today at our Health Equity Symposium, and we look forward to continuing our conversation.
Thank you so much for the invitation.